Hello, everybody, and welcome to my interview today with Dr. Miri Ben-Ami. I'm excited to have her with me today, and I just wanted to share a little bit of her biography before we get going into the meat of today's conversation, which I am so excited for. Dr. Miri Ben-Ami is a leading expert in women's health with a special focus on menopause and weight management. Now you can see why I'm excited to have her with me today. She has an advanced certification both from the North American Menopause Society and also the World Federation of Obesity. And she's very passionate about how these two areas intersect to impact women's health overall and also longevity. Dr. Miri Ben-Ami combines her clinical expertise with a holistic approach, right up my alley, including certification in medical hypnotherapy to empower women through their menopausal journey. She has also made a significant impact in biotechnology, leading research to bring new treatments to patients globally. Join us today as we dive into her insights on menopause and how women can thrive, very important, during this stage of life, because we are all, as women, no matter where we are, how we come into this stage, we are all going to go through menopause. If we have ovaries and a uterus, we are going to experience it. Welcome, Dr. Miri Ben-Ami. Thank you for being with me today and agreeing to give so generously of your time.
Thank you for inviting me to speak on this very weighty topic.
Yes, so today we specifically are going to focus a lot on the weight implications for menopause, the hormone changes that cause it, why it happens, what women can do in order to be able to combat it. But I think for me, one of the most important things I want to discuss with you today is just to give women an understanding of why this happens. Because so many women feel like their bodies are working against them, that they're struggling, they're frustrated. And I'm a firm believer that the more information we have and the more we understand these changes that are happening in our body, the easier the process can be, or certainly the less overwhelming and frustrating the process can be. And I also want the people in my world, my clients and the women who follow me, to really get an understanding so that they can advocate for themselves as well, because that is a big part of where I see a huge gap, is women just not being able to go to their doctors and adequately express the experience that they are having and ask for the treatments that are available to them. So what I'd like to start with is a question about how you got involved in this line of work.
Well, my dream was always to be in gynecology and obstetrics. I found that specialty really has everything in it: psychiatry, surgery, internal medicine, pediatric, everything. So it was really something that combines all worlds of medicine. When I was in my gynecology and obstetrics residency, I saw this TV series. It was in South Africa. I don't remember what it's called. It was about a gynecologist who opened a clinic and treated women who couldn't find solutions for what they were suffering from anywhere else, because it was very niche kind of issues. And menopause is one of them. I had a big break from medicine and I went into the biotech world when I made Aliyah to Israel. But I always missed that, even helping millions of people by bringing new medicines to the world, I still missed this one-on-one interaction with women. And at the time when I went back into medicine, menopause was a huge gap. Everything sort of, I got into it kind of a miracle. I didn't know if I'd ever get back into medicine, but there was a doctor from the States who was looking for somebody to help him in his women's health clinic. And I sort of sent my CV that was full with being a CEO. And I thought, oh gosh, okay, let me write something about my residency a long time ago. And it happened. So I started getting into it really rapidly. I realized how little is known in Israel. Today, it's a little bit better, but still very difficult to learn about menopause not in the residency and not in medical school curriculums. So I did that through the North American Menopause Society, the leading society in menopause. And that's how I got into it. So it's a bit of a miracle, a bit of grabbing what came my way, grabbing opportunities. I believe that's, everybody should sort of open their eyes. Now weight gain through the World Federation of Obesity, there are a few things that are intimately connected with menopause. And weight gain is, surveys and research has shown us that more than 60% of women are concerned about weight gain going into the menopausal transition. So it's very difficult to treat menopause really well without understanding all the issues around it that are interrelated with menopause. And because weight gain is such a huge issue, culturally, socially, physically, physiologically, that's something that I put into my toolbox so that I'm able to really see the whole picture, and like you said, look at everything holistically. And that's how I got here. Speak to you.
I love that. I love that you've combined both together, because it's something that I hear from women who want to work with me and clients who I am working with. One of the biggest frustrations that they have is not their hot flashes and night sweats. They complain to be more about other symptoms, and weight gain is a very big one, especially that a lot of them say, I haven't changed anything. I'm still eating the same. I'm still exercising the same. Some come to me saying they've tried to be more restrictive, exercise harder, and either that they see no benefit from it or their weight is going up. And it's actually interesting because it's something that I experienced for myself as well. I've had 2 jumps in weight over the last 5 years, which I put down to stress. I put down to other things at the time. But when I look back, especially a big jump that I had 5 years ago, yes, it was a stressful time. I had just moved to Israel. Yes, Corona was just happening. Yes, there were new foods that I was exposed to, but that wasn't the full story. And I think because I wasn't experiencing any other symptoms, you don't think of weight gain on its own as being something that is related to hormone changes. So I'd like to ask you, why does this weight gain or this redistribution of body fat, because this is also something that a lot of women complain about, this tire, this meno belly, this extra, women who've never ever had any issues with carrying fat over their stomach, all of a sudden there's this thickening that's happening. And if you can just give some insight into why this starts to happen, I think it will be very beneficial to hear from you.
Okay, so menopause, everything you said is related, and you can definitely blame it. The thing is that with the stress going on, with genetics going on, with aging going on, because women need to understand that pre-obesity and obesity is just like if somebody needs glasses, eyes get a little less sharp, blood pressure goes up. It's related to many facets in life. Aging, genetics, that's the main one. And then everything else that you mentioned, stress, culture, mental, emotional issues, they're all related. And then when that happens in the menopausal transition or menopause, then it just makes things that much harder. And what happens in menopause, there are direct effects and indirect effects. The only direct effect is really, as you said, the redistribution of fat. We can go why that happens. It moves from the legs into the tummy. We lose lean mass from our lower limbs, especially, but from everywhere peripherally. And then it moves viscerally into becoming central fat around our essential organs like liver. If it's in a more advanced stage, then even around our heart, epicardially. And that's why it increases a lot of cardiometabolic risks. So this is essentially the main effect of menopause on weight. The other effects are indirect. If a woman is in menopause and she's emotionally stressed, irritated. She's not sleeping well. She's depressed. All these issues lead to weight gain. When they looked in lots of studies around Europe, different countries, and they took women between the ages of 40 and 60, those that weren't in menopause and those that were premenopausal. They weren't even in their menopausal transition, and those that already entered menopause and were postmenopausal, and they looked at weight gain, and there was no difference in weight gain kilo for kilo between everybody gained weight, by the way, most gained weight, but there was no difference between those who were premenopausal and those that already went through their menopause. So weight gain, kilo for kilo, menopause doesn't have a huge effect on it. The main effect is the redistribution, and the real effects on weight gain are the symptoms of menopause and symptoms in life. And you mentioned some of them. So that's something that's very important to remember.
Can I ask, okay, first of all, I want to clarify. You said that the weight distribution changes. So we lose lean mass, which is muscle mass from our legs, and we redistribute weight onto our stomach. So even if the weight on the scale is not changing, we could be actually, even though our body shape is changing, it's from loss of muscle mass and then the redistribution of fat and around
the center.
Our stomach.
That's
okay.
Right.
All right. The second thing that you said, which I just wanted to get a little bit more into, because one of the areas I deal with a lot with my clients is the emotional component of menopause and the stress factor, and also sleep, sleep issues. How does the emotions, the stress, and the sleep concerns affect weight?
So there is what is known as, I know it's something that's counterintuitive. A woman could go to sleep at a certain weight. If she sleeps, she will lose it. She'll lose a kilo or two overnight. If she's not sleeping, she won't lose them, because cortisol, which is a stress hormone, might be going up, might be disturbing all those physiological patterns. There is energy expenditure also when one's sleeping, and it's a healthy energy expenditure, which might not occur if she's not sleeping. And there are many reasons. It's a known fact. Like I said, it's one thing is that if one's like irritated all night, the next morning you'll be slimmer, but it doesn't work like that. Generally, if the body is not functioning healthily, then it's very difficult to concentrate on weight loss, because weight gain is a survival mechanism. So if there are other things going on which are not balanced, are not as healthy as can be, our body is not going to have enough energy to burn the fat. And that's why it's so important to feel good, and I'll put in even feel happy. So the more one is stressed about gaining weight, and I see a lot of young women with tremendous pressure on them to lose the weight, the effects that it can have is just gaining weight.
Right.
So the first thing is to really, if it's hormonally, if it's emotionally, get everything in balance. Understand it's a multidisciplinary topic. So also always I refer to a dietitian, a nutritionist who's able to plan a process of how a woman can go through this journey happily without the additional stress of having to reach certain goals.
Right. So I think it's very important that you bring that up, because it's something that I also try and focus on with my clients, and especially when we are trying to get their eating habits optimized, encourage them to put their weight goals on the side in the beginning, even though it's very, like, that becomes their sole focus. They only want to look at the number on the scale and the number coming down. But the more they focus on that, the more stressed they become. And it sounds also, from my own experience with understanding how cortisol works in the body and how the lack of sleep can impact weight and eating habits the next day and stress eating, and how that all works together, that if we are so stressed and focused only on the number of this on the scale, then that adds extra stress and it doesn't actually always benefit us. So it's about getting some of the other parts of the puzzle into place. And what I try and encourage my patients with also is understanding how to nourish their bodies, to stop looking at foods as good and bad and rather focus on what is right for them as well. Because I find that also the foods that often we can eat in our 20s and 30s, we can probably get away with, but the minute that we also start becoming 40, 50, 60, our bodies process that food differently. And often there's also gut-related issues where women come to me complaining that they're getting more bloated, more gassy, foods that they could eat before they feel like they're not able to tolerate. So I think there's a combination of a few things at play here. And if foods on the healthy list or the good list are all of those which are giving them gas and bloating and discomfort, then they come even more frustrated because they know they should be eating that, but it's causing this problem, and then they're not getting any of the results that they want.
So I think I can add to that. As you said earlier, a lot of women approach me too, saying we're doing everything exactly the same. Women need to realize, and this is hormonally related as well. So we have the decrease in estrogen. Ovaries are producing less estrogen. We don't need so much estrogen because we're not in the reproductive stage anymore. We can go on break. We can resign from that tremendous physical task. So there are two things that happen hormonally. The estrogen goes down, there's more free testosterone, we get a beer belly. I guess it's a little bit like men. And it's not only from beer, it's also a testosteronic effect. So that's one thing. And the other thing, when we are cycling, we need a lot of energy. So our energy expenditure is much higher than when we finished cycling and we're now unstable. If we treat it, then even better, stable amounts of hormones. And we don't even need as many calories as we needed earlier. It's exactly like when a woman is breastfeeding. She needs so many more calories because the energy expenditure that happens is much higher. So it's true. The thing is that just preventing and saying, okay, well, now you have to eat even less than what you had. We have tricks of the trade. We know how to teach this is more your task. I sort of write a line and then send over to you, but it's really concentrating on foods, like you said, that don't make you feel bloated. You've got to really listen to your body, and also eat those foods that you love and eat those delicious foods. And everything is checks and balances, just finding things that make you fuller, finding the right time to eat mindfully all the delicious foods. So it's not supposed to be, it's not, a woman isn't supposed to suffer through this. And also yo-yo dieting is out. So we need to talk about lifestyles, something that a woman can do from the moment she comes in and brings the subject up. And we see that she would be very much healthier if she was able to get her weight onto a healthier zone, and then find a program that she actually manages to enjoy life and to take it up from today till 120 years old. So yo-yo dieting just does a lot of harm to the body because our metabolic rate goes down. And every time we lose weight, it goes down. If you can see my hand. And then when we put on weight, it goes down slower. It doesn't go back up. And then she loses the same weight she gained, it goes down. So when we get to older ages, 40, 50, 60, it's already on the floor. So it's best to just work with the metabolic rate and lose ever so slowly, and don't get those
drastic dives. So that's what you're saying, right?
It can never recuperate.
Right. So I just want to clarify that, because for me, my understanding of it is, and obviously also from a nutrition point of view, that the yo-yo diets and why they are so seriously bad for women at any age, but specifically at this age, is that every time we restrict and take in less energy, less calories than our body needs. Our body is using our own lean body mass, our muscle mass, for fuel first, which is what slows down our metabolic rate. And then when we normalize again, we have a higher body fat percentage to lean muscle ratio as a result of that, which means that when we are eating foods, again, which are more like in that yo-yo dieting phase, restrict, go down, and our metabolic rate is going down. We see the scale maybe going down at the same time. But then when we yo-yo back up again and we're eating more normally and can't maintain that level of restriction, then the weight gain jumps up a lot higher, but our metabolism never recovers from that. And that is why so many women who go on yo-yo diets and try, and they think that this is the right approach because maybe it worked in their 20s and 30s, when they come to me also in their 40s, 50s, and 60s, and I'm sure you see it in your practice as well, that first of all, they can't maintain it because they don't have the same I'll put it in inverted commas, willpower, motivation. Their energy levels are not the same to be able to have that level of restriction. Their ability to stay as focused on something like that is also reduced, which I don't think is necessarily a bad thing, but certainly more important than anything else, lifestyle is the word that you used. And I feel that that is the most important focus, because anything that you do that you cannot maintain on a long-term basis is going to be detrimental for you, whether it's going to be health-wise or whether it's going to be emotionally. And I think the emotional and stress implications for trying to restrict and drop weight at this age is what causes a lot more problems for women.
So I absolutely, just to encourage women, even if weight drops off fast, it doesn't always mean, if it's done properly, having enough calcium, the right amount of protein, exercising, it doesn't mean that there will be a high loss of lean mass.
Right.
Okay, so the loss of lean mass is not the speed of the weight loss. It's more that it's done without
including the right nutrients,
with professionals who can guide what the best way to lose weight. Gaining weight after losing happens when a woman cannot maintain the program she was on prior at all, if it is if it doesn't suit her. So if somebody is really struggling with 16-8 and she's a night eater, she likes to eat in the evening, and she's doing that, then she will put on weight very rapidly because the body is struggling and stressed. So by lifestyle, a woman can lose weight as quickly as a lot of medicine today, and hormone therapy can lead to very fast weight gain, weight loss. That is not a problem if she's doing it
with the right guidance and support. There are two things I want to clarify. You said 16-8. I'm assuming you mean fasting for 16 hours and eating for 8 hours. So let's maybe segue into talking about hormone therapy that can help with weights. And also, you mentioned other medication, which I'm assuming you're speaking about what everyone is talking about at the moment, which is a lot of the GLP-1 medications, things like Ozempic, Wegovy, and then the newer ones like Mounjaro, which is a slightly different,
the GLP-1 and GIP.
Yes, correct. Which seems to me to be much more effective, and I'm sure that there will be even more medications
in the pipeline.
In the pipeline, absolutely, with fewer side effects. Right.
It's really a fantastic time. Medicine is advancing in this area. It's helping so many patients that are class 3 obesity. I don't like saying morbidly obese, but class 3. There's the healthy weight, pre-obesity. Today it's called between 25 and 30, and then class 1, class 2, and class 3 that have lost a lot of weight. It works just as well as bariatric surgery for loss of weight, and obviously side effects are less. It's much easier to follow through to a normal way of life following just treatment with medications. So there are the medications, you mentioned them, they're all excellent. There are also oral ones, and there are others. And they're also very good. And it's fantastic because they can be tailored. The treatment for unhealthy weight gain can be personalized for each woman according to what she needs. Some of them also help, most of them help with cardiometabolic issues that start, pre-diabetes and fatty liver. So they are wonderful, wonderful treatments. A patient of mine came in, tried them all, and they told her that she only could do, the only thing that would help her would be bariatric surgery. And I said, okay, well, and she didn't want bariatric surgery. I said, okay, we'll give it one last go. If it doesn't work, then I agree with your endocrinologist. Probably this is what you need to do because it's becoming very risky. A very young patient, 27 years old. So what we did was we gave her what she got previously, but we tapered the doses in a way that would suit her, that would not lead to side effects she couldn't stand. And she lost 35 kilos already. And she's not even in the criteria for having any surgery done. So everything changed, her back pain, hormonal issues got better. So there's really, all these things are available, and it's really just going to the right physician, getting the multidisciplinary approach, and knowing not only what medication to give, but to fit it exactly to the side effect profile, the patient's family history, genetic history, medical status, and also give the dose in such a way and in such an amount that will help the patient stick through it happily and get to her health goals. Right. So it's really all there. So it's, even now there's what is called the best one, and they all lead to excellent weight loss in different doses for different women. Women are so unique. So in my opinion, it's great that there's more advances, there are more trials in phase 3. I'm happy because there's still some very harsh genetic problems, and we don't see many of them because they're very rare, like Prader-Willi and lots of and those that have too little leptin produced. So specific genetic problems that those new drugs are going to address, which is wonderful. But today, a woman that suffers from any issues concerning weight gain, there are so many things available that she can just pick. Now, talking about hormones, hormone therapy is synergistically working with the medications. They've just come out with a study showing that a woman taking, and talking about semaglutide, that's a GLP-1 agonist, a woman that they looked at all women using the GLP-1 weekly injections, and they compared the weight loss of those that were on hormonal therapy and those that were not taking hormonal therapy. And hormonal therapy with a GLP-1 led to 30% more weight loss than GLP-1 alone. So that's incredible. Wow. It's incredible. And the thing is that it makes sense because even those before, or those that don't need to go on diet medications, everything we talked about, the estrogen levels being low, the redistribution because of that, the symptoms, hormone therapy helps with all of that. And so naturally, it's expected that they will help to maintain the weight a woman is in, if it's a healthy weight, and also if a woman is suffering from pre-obesity or obesity, hormones definitely help to lose that extra weight.
So that's what I want to ask you about. So let's speak about now somebody who comes to you who doesn't have hot flashes or night sweats, because what I find that a lot of my clients are coming up against with their family doctors who maybe are not the right people to be prescribing, but even gynecologists or obstetricians who they've been using for years, they will go and they'll complain that they are experiencing, some other symptoms of perimenopause and menopause, things like brain fog and the weight gain and joint pain, and what I certainly experienced was just this feeling of just like no joy. There was an amazing podcast I listened to by Mel Robbins, who spoke about something called anhedonia, which is just this lack of joy in your life, that you're just on the same cycle day in and day out. You get up, you repeat the same things, you have no energy, you're not sleeping very well. So unless they specifically say to their doctor, I'm experiencing hot flashes and night sweats, they're not necessarily going to be red flagged as somebody who needs any form of hormone replacement therapy or menopause replacement therapy. And even in some cases, I had a client who went to their doctor complaining of hot flashes, and the doctor said, it's not time yet. Let's wait a little bit longer. So how are these medications helpful? And a lot of my patients also, or my clients that I work with, are scared to take hormone therapy because of this big, maybe we can speak a little bit now about the myths behind it as well. The Women's Health Initiative that came out in 2001, 2002 with these scare tactics about what hormone therapy could potentially do. So I'm asking a lot of questions all at once. Sorry. Okay.
No, it's okay.
Okay.
I remember.
So let's speak about the woman who go to their doctor who does not have hot flashes and night sweats. Why should they motivate for using any form of hormone replacement therapy? How does that benefit them, even if they're not experiencing hot flashes and night sweats?
Okay, so two essential big questions. The first one is easy to answer. The second one is risks, benefits of hormone therapy. So we'll get some myths in order and see what's real, what's not real. So the first one is really easy. See another doctor. Try find a doctor who understands menopause. Okay, there aren't many specialists in menopause here, but and if they don't, because don't wait for your doctor to bring it up. Bring it up with your doctor. If you see that there's less understanding in the material, go to a new doctor. That's absolutely what a woman owes to herself. Okay, so that question was easy to answer. The next question about hormonal risks, because any symptom that a woman doesn't feel herself, even funny symptoms, I get the funniest symptoms, not related, still they're probably related, because if it just suddenly happens, it doesn't matter. Everybody's completely stressed with the war we have on multiple fronts. We're going through such hard times, little bits of light here and there, but so tough. Still, you want to be able to deal with everything as best you can, and you deserve to get your fuel back into your body if you're at the stage of life when your fuel starts going down. So find the practitioner who will help you. That's the first one. Hormones. Since 1940, when the first hormone was approved by FDA, it was Premarin, synthetic estrogen, there have been tons of studies, of research. I know people think that women aren't involved in clinical studies. This is true. In heart attack clinical trials, in cardiovascular, fine. But in menopause, it's only women. Okay, so
I should hope so.
So that we were in, I think males have a harder time with andropause, not many studies on andropause, but anyway. So since then, we've had lots and lots of study, and each study adds information that doesn't contradict information from a study before, which is fantastic. And what the study in 2002 added was that a certain type of progesterone, MPA, leads to an increase in breast cancer after taking it for 5 and 7 years. We hardly use, we don't use, maybe there is a place for it rarely, but it's mostly not used, MPA, for menopause because of this fact. There are other synthetic progestins that have shown an increase of 5% in breast cancer after a few years of using them. So we try and use them as little as possible, especially in women who have a history of breast cancer, or obviously who are survivors of breast cancer. But we know today that the other, progesterone, doesn't increase risk for breast cancer, and estrogen, in fact, protects against breast cancer by about, if I remember the number correctly, 16%. There was an epidemiological study with 10 million women showing protection against quite a few cancers, among them gynecological cancers as well, also protecting the heart, protecting the blood vessels. So another thing about the bad progesterone, not the progesterone, the progestin, it's a progesterone analog, is that it increases breast cancer by 5%, by 4 women to every 1,000 in 5 years, by an additional 4 women. And obesity, a BMI of about 30, which is about 8 to 10 kilos more in a 1.60 m woman. It's about 10 kilos more than the 60, 70 kilos and up. The risk of breast cancer goes up by another additional 24 women per 1,000 women. So it's 8 times more than the bad hormones. So it's a bit of a myth, and I think this is something that doctors can prioritize if, in case they need to take the hormone, which just does increase the risk. But mostly we know from this large epidemiological study and other studies that hormones are more protective than risky. And if you take out that risky side, the risky progestins, hormones are protective. Generally risk-free. So this is huge. I can tell you even more so, all the guidelines allow us, the NAMS guidelines today, Menopause Society and other societies, leading societies in the world, guide us that there's still not enough data to show that women who suffered from breast cancer, they can very quietly take hormones. There aren't millions of women, but the most recent study in 8,641 women showed that after surviving with breast cancer, estrogen therapy did not increase recurrence risk. On the contrary. So after being treated with tamoxifen for 5 years. So estrogen has also a protective effect, not just a proliferative effect in general, but we know that it doesn't cause breast cancer. We just aren't 100% sure how to deal with the question whether when there is cancer already, whether it can feed it or not.
Right.
So, but the guidelines say that you can treat women if you've tried other things and she's still suffering. You can intelligently treat her in cooperation with an oncologist with hormones, systemic hormones, and I assume intelligently means to pick the hormones which don't increase the risk.
Right. That's fascinating you bring that up, because I have a client at the moment who is still receiving like a tamoxifen, not tamoxifen itself, I can't remember the medication.
Aromatase
now. Yes, it's an aromatase inhibitor for an estrogen positive, hormone positive breast cancer, and her doctor refuses to give her any estrogen at all. So from what I'm understanding, you're saying that in that study, it was the synthetic progestins that were more of a cause for breast cancer risk, if any, not estrogen. And estrogen has got the worst rap.
And the synthetic progestins.
Right.
Not the
micronized progesterone. Right. So estrogen has got a really bad rap, is what I'm hearing from you, because at the end of the day, I believe, and maybe you can clarify a little bit more about this, it is incredibly protective in so many respects. It's cardioprotective. It's certainly from a bone point of view, from osteoporosis, it's very protective. Is it not protective for the brain? I mean, estrogen touches every single organ and almost every single cell in the body.
Receptors in the brain as well.
Right.
So when you said initially, ovaries and uterus, that's correct. That's a main role we have during the reproductive years. Obviously, we're using our brains, otherwise we wouldn't be able to pull it through. But our brain is full with estrogen and progesterone receptors. So estrogen and progesterone, estrogen is known to reduce the risk of Alzheimer's disease. Progesterone is known to reduce the risk of dementia. So with our shift of role from a reproductive one to a wisdom, wise, counseling role, this is something that's really important to keep us healthy and doing what
cognitively healthy, to be able to take all the wisdom that we've gained out of our lives and actually be able to live and thrive, as we discussed in the beginning.
And so we don't need to have hot flashes for some kind of proof that we need hormone therapy.
So it's enough for a woman to come to her doctor and say, even waking up, I'm not feeling myself. Right.
Even if it's just in my head.
Right. So how does estrogen and progesterone affect things like serotonin and dopamine in the brain? Are there direct implications for the lowering of estrogen and progesterone on those hormones that help us to feel so positive and motivated?
They're around the same receptors. So estrogen works. So estrogen can also work as an antidepressant. It works on the same receptors. And although it doesn't have the same side effects, which is nice. And that's why also things like Cipralex, SSRIs, also reduce the amount of hot flashes, not as well as estrogen, because they're working there on the thermoregulatory mechanisms in the brain. So yes, very similar mechanisms. Progesterone more on the neurotransmitters of excitation, GABA receptors, and that's the calming effect that it has on the brain, and that's why it also helps with sleep. And I'm talking about the natural hormones that we know exactly what receptors they bind to. The synthetic ones bind also to different receptors, and they have different effects. So when I'm talking about progesterone and estrogen, I mean the ones that are similar, if they're exogenous, similar to what our ovaries producing, or what our ovaries producing, that's the effects they have on the brain, which is fascinating because, you know, progesterone can work a bit like a benzodiazepine, like the Bondromine and Lorivan, without the side effects. Progesterone helps with maintaining memory, while the benzodiazepines lead in the long term to reduced memory. So
because it's natural, that's what the body needs. Right.
It's all there just to get. And you know, another thing is that especially women suffering with weight issues, it's quite a journey. It's not an easy change to make, even though it's very important to get the guidelines to do it mindfully and happily, but really getting the body as help, getting the fuel back so that a woman will be able to do that, and without any mental, emotional issues as well. And when a doctor gives a patient, and I have many, it's getting less and less. I think knowledge is out there, and you and I are trying to distribute this as well. It used to be automatic that women used to get psychiatric treatment for menopausal issues. Now the effects, the side effects of Cipralex, for example, which is the most popular, but all the SSRIs are weight gain, which is especially if a woman is already genetically with a propensity to suffer from weight gain, lowering libido, which is not something which is nice for menopause either, and the flattening of affect. So some women that would be okay, but women like to feel real happiness when it's there, even though if we can cry when we're happy as well, and the sadness. So it doesn't specifically flatten the effect of the sadness or the anxiety. It does also with the happiness. So women in menopause, if it's a psychiatric issue, if it's an organic psychiatric issue, these medicines are fantastic. But if a woman starts having all these symptoms as she goes into the menopausal transition, it's so much easier to first give the fuel the body needs and see where the woman is at. And if she's feeling great and happy and able to lose the weight and able to carry on with her life, it's a pity to bring in treatments that give side effects of something that would not suit that specific
Okay,
woman.
so I want to be clear, and I think this is very important because I see and I hear so many women being put onto SSRIs, and yes, there's a place for them because they are feeling anxious, depressed, low mood, where it's a feature of estrogen levels declining. And if they were just to be provided with the right dose of estrogen, and maybe there needs to be also progesterone if they have a uterus, they still need to receive progesterone as well.
Well, if they don't have a uterus, if it was removed, the brain needs progesterone as well.
Right. Okay.
And progesterone after removal of a uterus still protects from any microscopic uterine cells that are left there.
Thank you for clearing that up. Very important. Okay, so my advice is changing.
The balance will be different for each woman. Some might need just progesterone initially, some may need more estrogen. So it's really a matter of balance between the two.
Okay, so all right, so let's talk a little bit about the types of hormone therapy that are an option, because I know there's oral, I know that there's patches, I know that there's gels. What determines what somebody should be taking? Maybe you can just give a little bit,
I think we sort of covered that because there's so many different types. There are approved natural hormones, there are synthetic hormones which are safe. There are, like you said, transdermal, skin, oral. Each woman needs to see a menopause specialist, and we go through her whole history, her background, her medical background, her family's medical background, her symptoms, and it's completely different for each woman. There are places for synthetics, there are places for natural. Mostly in menopause, we don't need very high doses. So the natural hormones are gentler and they work perfectly. So we don't need to stop ovulation, as in oral contraceptives. Oral contraceptives are not known to increase breast cancer. So there are good synthetic ones as well. And so it's really a fit. Sometimes women in perimenopause, if they're having a very difficult time with very heavy cycles, non-stop cycles, sometimes going on to something synthetic, which is safer from the risk point of view, will be a better idea. So again, it's so wonderful that we have so many options available, and we just need the medical community to have the knowledge and be updated and really work according to what each woman needs.
Right. Okay. So more than anything, it's important for women to see somebody who understands what the options are available for them and spend the time, and this is what I love about you, spend the time taking that full history, because, you know, and it's unfortunate that in the national healthcare basket, women really have not a lot of time to spend speaking to a doctor. And I don't feel that there's always enough information taken or time given in order to be able to determine this. So I'm hoping that there will be changes with that over time, or maybe that nurses will be able to also become more educators, or maybe dietitians, you know. Certainly that's what I'm trying to do, is just to have enough knowledge myself to be able to advocate, so that when a woman can go to their doctor, they already have all of the information that they need to be able to say, this is what I need help with. We've covered so much, and there are one or two points that I want to finish with you. I think one thing in particular is, if we can just touch on, you know, women feeling this feeling of being betrayed by their body during menopause, that, you know, they've been so active and so reproductive their whole lives. They've had children, if those who have had children, carried babies, nursed, been these caregivers for so long, and all of a sudden, sometimes overnight, it feels like their bodies are just not their own anymore. How can they find a balance between accepting these changes and also striving for better health? What advice can you give for somebody who's really struggling with this?
Okay, so our bodies are with us Okay, they're not betraying us at any moment. They're really doing their best for years to carry our spirit, our neshama. Okay? They're our vehicle, okay? And they're much better. I think Ferraris need to go for, I don't know, yearly checkups. So they need fuel all the time. So what happens in menopause is simply our body goes through what our mind goes through. It's like living on 6 cups of coffee every morning and then going down to 1 overnight. Our body needs to get used to it. So we were in top form. Men can't even imagine what we go through with our cycles and our reproductive years. There are so many issues. It's just that we're so well covered with medicine around these issues that we just go through them, but they're not any lighter than the issues of going into menopause. Okay, women suffer from PMS, premenstrual syndrome, and premenstrual dysphoric disorder, and weight gain, and IVF, and abdominal pain, and
Endometriosis and PCOS and
endometriosis,
everything,
polycystic
right?
ovarian syndrome. Okay, so if I had to ask if the listeners would put up their hand each, I think everybody has something. So it's just the mindset that it's connected with aging, and most people say, well, just deal with it, that we feel like, but our body is with us. It's just going through a sudden, unspoken of, better today stage. So sometimes even I have a lot of women feeling that they've put on weight, they're eating the same, they don't know what's going on, they feel older. And looking in their history, I see a genetic propensity for osteoporosis. I see that they're weighing, their BMI is 19 or 20, which is even a higher risk for osteoporosis. And I tell them, your body loves you, that you've gained a few kilos, you're protecting your bones, so you're going to be a sexy elderly woman and not one that's breaking down, her bones are breaking down completely. So enjoy it. So you don't expect your body to get into the genes you got into when you were 16 or 18 or 25 or before you were pregnant. This is a good thing. The body does go a bit into survival mode. It realizes it can't get its 6 cups of espresso coffee every morning, and it's only got 1 now. So, and maybe 2 or 3 if you add some hormones in there. So your body's saying, okay, please, I need just a little bit more coffee. So, sort of work with your body. Speak to your body. This is the hypnotherapy part. Speak to it. Say thanks. Thanks for everything you've been both together. And okay, this is easy because we have our higher source, our higher being, Hashem, has given us the knowledge, has given us this advancement. It's like a girl who has very heavy menstrual cycles, daughters, and they're very weak. Nobody's going to tell them, just deal with it. You're going to give her iron. And that's exactly the same with dealing with menopause and treating it and listening to what your body needs. Your body, I tell a patient of mine, she will say, why do all my friends go through menopause so easily and I have all these symptoms? I said, say thank you, because these are red alerts that your mind needs something, some fuel, and your body needs some fuel. So it's better than coming to me at the age of 65 and there's already osteoporosis and diabetes and cardiac issues.
So I love what you said, because it's very in line with how I work and the message that I give my patients and my clients. The most important thing is I say you've got to work with your body, not against it. And I encourage my clients to listen within to the signs and the signals and the messages their body is giving them. Because if we're ignoring it all the time, like as you say, these are red alerts. These are our bodies saying, these are signposts of the direction that we need to go in order to be able to support our body the best way possible. And if we're ignoring them, and I think the frustration comes a lot when our body's doing something different to what we want it to be doing. But I find with myself, especially, like I've had to become so aware of my capacity on a daily basis, of what I can do and what I can't do. And it's different. I mean, I'm not in menopause yet. Can't wait for the day that you say to me, here you go, here's your HRT.
You've got the right attitude.
Right. So I'm still cycling, and I can feel before my period how my estrogen dips. I can be teary for no reason. I can feel my energy is completely low. So I pace myself accordingly. I'm not going to expect myself to do the 20 things maybe on my to-do list on a day like that. And even if I wake up in the morning and it's a day where maybe I expected to have more energy, then I'm going to reduce the expectation as well. And I think that's a very important part of this, is to listen to our bodies, to work with our bodies, to understand what our body needs. And in that way, also saying thank you to your body is the most beautiful thing ever, because then it's allowing for connection. And I think a lot of the time we feel so disconnected from our body, especially when it's doing something that we don't understand or we don't expect, or we want to be different.
Absolutely. I agree with every word.
Amazing.
And good luck with your menopausal transition.
Thank you. Right. I wanted
to...
if you could give women one actionable takeaway about menopause and weight, what would it be? What's your final message for us today?
Breathe deeply, and maybe 2-3 actionable items.
That's great.
The first one is to breathe deeply and know that it's a wonderful stage in a woman's life. Freedom from cycles, knowledge, wisdom, time to counsel everybody around us. And it's really a time with low-hanging fruit. Everything to feel wonderful is available. So it's just to pick these low-hanging fruit and eat them. They're delicious. That's what I would suggest.
Amazing. Dr. Miri Ben-Ami, thank you so much for your expertise, for your wisdom, for sharing in such a beautiful way that I think is so incredibly important. And I just hope that more women find their way to you. I certainly send many women your way. And
to help everyone. And really, you know, women just need to search for the help, anyone that can help them. When we're talking about weight, it's a multidisciplinary approach. And I thank you for bringing this to the front.
Absolutely. It's so important. So thank you so much for sharing your expertise and your time today. And take care.
You too. And health for everyone. Health and good news. Bsorot tovot.
Amen. We really need it right now. Thank you.
Bye.